introductions. I'd like to welcome you all to the Prevention Research Center for Healthy Neighborhoods seminar series. I'm Sue Flockey. I'm an associate director at the center, and I'd like to welcome you back to this if you've been here before, and certainly welcome all the new attendees at this conference. This is a monthly seminar that we hold. It's the second Wednesday of every month. And we invite individuals from across the university and across the community to present about issues of prevention and health promotion. Today's speakers come from the Department of Bioethics, and we're delighted to hear about this project. Actually, Aaron was reminding me that he presented a very early version of this. It was probably about 4 years ago that happened, because we were still upstairs, and it was one of the very first seminars that we had. So, delighted to have an update on this project, and as it's continuing to move forward, and to hear about the new phases of it. But with that, I would like to introduce Aaron Goldenberg, who is the assistant professor and an assistant director for the Center for Genetics Research, Ethics, and Law. His primary appointment is in the Department of Bioethics. And then is going to tag team with Patty Marshall, who is a professor and the co-director for the Center for Genetics Research, Ethics, and Law. Their project is called Community Voices, Family History, Place, and Chronic Disease. Our general format is to present for about 45 minutes and then open it up for discussion. And I look forward to a good presentation and conversation.
Thank you. Well, it's great to be back. As Sue mentioned, this is kind of an ongoing project that really started 5 years ago. And what will happen today is I'm going to kind of do a very just quick introduction, and then Patty's going to kind of get into a little bit of the history of the project, some data that led us to where we are now in thinking about family history. When we started this project, family history wasn't really, and neighborhood effects and space and place weren't really on our radar screen. We were really thinking more broadly about genetics and health disparities. And the data that we're going to show now is kind of our evolution that we kind of went through over the last 4 years of kind of thinking about where our community partners are when thinking about genetics and family history, where we are. And it's really been an evolution that is that is not just the work that Patty and I did, but really the work that we as a team did. So that included other people in this room, including Laura Morello, who's been really essential for kind of thinking through this project. Carrie Cologne-Zimmerman, who's also in this room, who's one of our kind of research gurus for the original project and kind of helped us to think. And then a few others that we'll mention throughout the project, including someone who many of you may know, Chris Hartman, who was one of our research assistants, did some work with the Prevention Research Center, I know, and is now just about to finish his PhD at Ohio State. And is looking for a job.
Urban geography.
Yeah,
right?
yeah, and
is that cool?
And a few others, including Sandra Brooks, who's now working in D.C. as a fellow for the Office of Human Research Protections. So this project was really kind of born out of a team effort, including community partners that we'll mention in a little bit. One of the things that we, started to see in our data had a lot more to do with family history than we had kind of originally anticipated. We knew that we had already kind of conceptualized that family history as, I'm skipping down to the bottom, as kind of a genetic test, right? Thinking about family history as a way to kind of think about what runs in your family in terms of heredity. But we didn't kind of anticipate how much of space and place and other kinds of things were going to kind of come out in our data as it relates to genetics. And so that's what we're really going to talk about today. But, everyone in this room, we've all kind of done work in one way or another related to family history. It's a commonly used risk assessment tool. whether or not that's used as a genetic test or whether or not it's used as risk assessment thinking about social and behavioral health depends on who you talk to. And there's some literature that kind of leans more towards thinking about family history as, kind of that genetic test, the idea of kind of heredity. And there are other parts of the literature in family history that think of it more as risk thinking about familial practices, behaviors, social and physical environments. And that's one of the things that we really wanted to tease out in this project, is that kind of conceptualization of family history as either genetic or environmental, but really as maybe both, and how clinicians and patients think about those kinds of things. And so, we know that family history in its current form assesses, presence of familial diseases, both chronic and acute. It can assess things like behaviors like smoking or exercise, eating habits, those kinds of things. And it really, there aren't, I don't know if there are any card-carrying geneticists in this room, but geneticists really look at family history as a genetic test, maybe very differently than some of the people in this room, right? When a geneticist thinks about family history, they think about Punnett squares, and they think about that kind of basic pedigree that we all remember from our high school genetics classes. And so I do think that there's potentially maybe a disconnect between the ways in which people in this room may think about family history and the ways in which geneticists might think about family history, although that's an empirical question, I'm not sure. But we also know that there's a lot of attention being paid these days to thinking upstream, thinking about, this is really what this center was founded on and what a lot of our work centers on. And it's also happening in genetics. So while we may have different views on family history within the genetics community and within other health promotion communities, there's definitely a recent push within the genetics and genomics fields to start taking family history a lot more seriously when thinking about evidence-based medicine. The new President's Precision Medicine Initiative has a strong component of thinking about family history as an important part of the data collection for the Precision Medicine Initiative. And there's a number of examples where this idea of family history is a companion to genomics, right? And this is where we're starting. This is hopefully where we'll also end, which is that as genomic technology, so genome sequencing, whole genome or whole exome sequencing technology, starts to get integrated more into medical practice, people are starting to realize that that information is limited if you don't know the experience of the patient, if you don't know the family history of the patient, if you don't know where they live and what their experience and what their behaviors are, that only having that gene information is really, really limiting. And I think that where we hope to end today is to come back to this issue of how we can move forward in a project that we really want. This is really a work in progress. We want your advice and your thoughts on how we can kind of move this project together and thinking about how you might develop a project on family history that brings together, let's say, family medicine and genetics and bioethics in a really unique and hopefully really collaborative way. So with that, let's move backwards in time a little bit. I'm going to hand over the reins to Patty Marsher, who's going to kind of give a little bit of background of this project and some data that kind of points us where we've gone in the family history era.
Thanks. Good afternoon, everybody. And I'm so happy to see some familiar faces. Carrie, it's really, I'm so happy to see you again. Thanks for coming. So we're very proud of this particular project. Erin and I were fortunate enough to be awarded one of the so-called challenge grants that Obama and one of what are they called? The ARRA grants. So we were one of the few bioethics projects that were funded nationally, and what makes it particularly remarkable is that our entire study is qualitative. So we both do empirical research, but we use multiple methods, quantitative and qualitative. This particular study was qualitative. We used only qualitative approaches, and the primary goal that we had was to assess the knowledge and beliefs of low-income blacks, whites, and Latinos about genetics and its relationship to health disparities, and we were very interested in attitudes about genetic research. So that was our primary goal, and a very important goal related to it. We felt that it was essential that we engage with local community members even before the project began. So in our minds, it was very important that we give something back to the people who were involved, to the participants, and those within the communities where they lived. And we were successful in achieving both of these aims. Okay, I can use this, Susan, to... This gives you an idea of the work that we actually conducted. We did 12 focus groups. Actually, did we do 13? 12.
Yeah, one was a pilot, yeah.
The first was pilot. 12 focus groups, and we also did 121 audio tape in-depth individuals. And so, again, you can see what our goals were. The project was truly community-based. So before the project began, even when we were writing the grant, especially Erin was successful in partnering with a number of local community organizations. So when we submitted that grant, we had a community advisory board. And when we got the grant, they helped us review the informed consent for the project. They helped us, they made recommendations on the instruments that we developed for the focus group guide and the interview guide. So they were active all the way through. These are, gives you a sense of who the participants were just from a demographics perspective. These are figures represent the 121 individuals who we interviewed. You can see that ethnically they were pretty much evenly distributed. A few more women, 60%. No, actually, it was about even, men and women. The mean age was 37. You can see that these individuals come definitely from a low-income background. 70% earn less than $15,000. So it was an impoverished group. Education, 25% less than a high school degree, 25%. And nearly 50% had a high school degree. So relatively low educational levels. Medical insurance, about 60% had insurance and the rest didn't or didn't know. So we want to share with you some of the comments that individuals made in relation to a number of different themes. So this first theme that we're going to present here is on their not really views, but what they were telling us about where they lived, about the space where they lived. There's a lot of things that would restrict exercise. So here, this individual is commenting on the connection between a need to have physical exercise, but factors like safety that represent a real obstacle to being able to pursue it effectively. Z Street, yeah, like it's right down the street. So here again, there's a social environment that that represents, obstacles to really being able to effectively take care of yourself. And this individual is making the connection to physical problems and health. Every elder in my family has diabetes. I think when I was 12, they told me that I have signs of getting diabetes, but there's nowhere to exercise. But not even everybody can play just because there's not that many activities for the kids to do. There's nothing you can do in the inner area of Cleveland, in the inner city. This is all very familiar to you in this room, I think. Okay, pollution. These comments really call attention to unhealthy environments. Standing outside, all the exhaust fumes and stuff like that, that's an example of an environment that doesn't help because it goes inside of your body. So I think after time that causes damages to major organs. You are what you eat. You just get a lot of greasy food, chicken, things like that, and it takes a toll on your body. I grew up on the wrong side of the tracks in Dayton, Ohio. Why, it's just shocking that I'm here teaching, and I have now. But one of the things that we ate routinely when I was growing up, we didn't have a lot of money. Mom would take a piece of bread and dip it in bacon grease. There were 5 of us kids. She dipped the bread in bacon grease and take one piece of bacon and slice it in half and then put it on the bread, and that was breakfast sometimes. We always had a jar of bacon grease sitting on the stove. So when I think about, on the other hand, we ate tons of vegetables and homemade bread a lot. Okay, older homes. Here, she's expressing an awareness of problems associated with lead. And I know recently in the newspaper there's been some attention to that. Okay, in these quotations you're going to see really an awareness that individuals have about social environmental impacts. If you're a doctor or a nurse, when you get up there, and if you don't live in the community, you really may not know about some of the things that your patients are facing. If that family may have to bounce from house to house because they lost their home or what, do they have access to the food? Do they have even money to get the food? Anyone's at risk for getting anything. It all depends on what you do, where you live, how you eat, stuff like that. I think environmental factors play a lot with that, like pollutants and even your diet. So the point that we want to make here is that there really is a strong awareness about a broader picture, about the interconnectedness, the interrelationship between a number of social and environmental factors. Gene-environment interactions, well, of course, this is what it's all about, isn't it really, at some fundamental level, how we wind up sick, how we wind up ill. The point I'm making is that all diseases have some genetic, some physical, environmental factors involved in their progression. okay, it's just about the different factors compounding. For instance, if you're African American and you're at increased risk of cardiovascular disease, and you're living in an economically disadvantaged area, and all you have around you predominantly are like liquor stores and fatty food places, places where you can't get fresh vegetables and fruits, you're already at an increased risk for cardiovascular disease, and you might not have the funds to go see your health provider. So these factors combined make you a lot more susceptible to succumbing to the effects of whatever you're prone to. That's this individual is being extraordinarily articulate about the synergistic relationship between these factors and how they impact what happens to you, what happens to your health. Systems, not just healthcare systems, but local public structures, institutions.
Yeah, that's great. So once we started analyzing the data, and this is actually where I can't stress the importance of amazing research assistants and associates. We really relied on Carrie and Laura and Chris and Sandra to kind of roll through this data and really spend some time. And they came to us one day and they said, we're seeing a lot about family history here. We're seeing a lot about neighborhood. We're seeing a lot about space and place. I wonder if we could do something more with this. And so Chris, while he was here, and then Laura, as she's kind of moved on in our project, started to think about who in our kind of group of community partners might be interested in thinking about family history in space and place. And as many of you know, Neighborhood Family Practice is one of those places that is always thinking about these kind of things, has great research relationships, has just amazing people. And so we approached them and started to talk a little bit about this idea of family history and where family history is in their system and kind of how they perceive it. And one of the things that we heard in a couple meetings is that they felt like over the last few years, the importance of family history has been kind of slipping from their grasp for a number of reasons. One, because of just kind of the complications of new health systems. One of the things that we heard a lot is that electronic health records has actually made family history taken a lot harder. And for lack of a better term, there's not as many visualization tools in the electronic health record. So when they want to go back and look at a family tree, there aren't that many places to do it. And a recognition that while they were using the kind of more traditional family history, things like neighborhood and place and space just weren't being accounted for. They were accounted in other ways. It doesn't mean that they weren't accounted within the structure of neighborhood family practice, but not associated with family history. They had to be done in other ways. And so working with neighborhood family practice, we really started to think about ways to conduct some pilot interviews and we conducted 40 pilot interviews with patients at neighborhood family practice, and about 10 or so. Yes, we did one focus group and then about 10 interviews with NFP staff to look at perspectives on family history. So we wanted to get at this kind of concept of, do you think of family history as genetic? Do you think of it as environmental? Do you think of it as both? Do you not think of it at all that way? Is it just a pure risk assessment tool? We wanted to talk about this idea of expanding family history, how you might be able to think of maybe what we've kind of been talking about as a gene environment family history. And kind of other views. One of the things that working with NFP has helped us to kind of develop a relationship where we're also asking just questions that they're interested in, things that can help them serve their community better. And I know many of us are working with a neighborhood family practice, and so I think they're eager to try to do more kinds of things that will help them serve their patients as good as they can do. So some of the perspectives that we heard from the patients, right? So most patients understood family history to be really about assessing their disease risk, and I wouldn't say that we really saw genes or environment being really heavily talked about on either side. It was really more about that kind of basic risk assessment. Some of the participants kind of voiced some things that made it sound more like gene-environment interactions, and some just said, well, I don't know if it's genes or environment. It was just about risk. It was just about finding out what I might be at risk for, what my family might be at risk for. However, among both patients and providers, there was kind of a shared there was something that family history was not something that was consistently asked anymore. That it was, when you first went in, it was the first thing you did. When you signed up, you did your family history, and then it was after that initial visit, it was never followed up on. So any changes weren't recorded, and both providers and patients talked about this kind of need to follow up a lot more. There was also a lot of interesting quotes of that there was too much focus on chronic disease, not enough about what's going on immediately for patients, because it was only in that initial visit that the kinds of things that were asked didn't get at what was happening for them today or in the last few weeks or in the last few months, and they were wishing that family history could start to do that more accurately. So many patients saw the value, so in terms of expanding, so we asked them questions about what else would you want family history to ask? What else would you be interested in your clinicians asking for? Many people talked about the value in being able to share additional knowledge about their lives. Patients discussed the idea that maybe if they could be more open with their clinicians about what was going on in their neighborhood or in their lives, that it might lead to better referrals or better care. Although this was balanced against kind of concerns that sharing too much was going to they were either going to be judged or being, sorry, spelled wrong, that they were going to be judged by their clinician, or that it was going to kind of take away their kind of hope to kind of be self-reliant and and do things on their own, that they were going to maybe rely too heavily on their clinician. And this has raised some questions about whether or not family history needs to just remain within the clinical setting, right? How else can family history outside of the clinical setting help families and communities think about what they're at risk for? That clearly the clinic is a place where you start to have that connection, but how can you take that away from the clinic and use that within communities more robustly? Providers also kind of really like this idea of an expanded family history. And they really liked the idea of being able to, in one tool, for example, assess access to fruits and vegetables, access to transportation, but at the same time also assess kind of more the genetic or environmental diseases that a family had, but they also had some concerns, right? So they had the concerns about potential increase in senses of helplessness, that the more and more we hear about structural barriers, the more and more we're going to feel defeated because there's not that much we can do as a clinician in this one visit to kind of help to defeat those structural barriers. But there was some ideas about the ability to use this kind of multifaceted tool to connect to other neighborhood and community resources. Like maybe this tool would help to, use United Way's 411, is 311? 211. Yeah, 211. I was getting numbers. 211. Or maybe thinking about other health advocates or health coaches, that maybe this tool could actually help to identify places where neighborhood family practice could be doing more outreach to other community resources and work together to say, look, we've now done this kind of assessment. We better understand what's going on, not just for this patient, but in their family and their community. Let's all work together. And there was some excitement among the providers about the potential of having that information in a different way. And so we've been thinking both within this project and before this project about this idea of the possibility of tool development, the idea of a gene environment-based family history tool that would assess environmental exposures, physical environment, social environment. One of the things that's come out of our conversations with some of you in this room has to do with the difference between kind of perceptions of exposures versus actual connections to actual exposures, and thinking about how you might connect, for example, family history with neighborhood dashboards, and thinking about ways that you might be able to connect a family history tool in a really interesting way with other kinds of data that's been collected by us, by others, that could help to kind of get a fuller picture of kind of these gene environment interactions in communities. And so that it could be used, and that the hope would be that this would be utilized by both family practice docs, individuals and families, health navigators, communities. And so before he left, Chris was just trying to just jot some things down. So this is by no means a developed tool. This was just Chris Hartman's attempt to say, how could we do something? And he was doing this in consultation with the others on our team. But he was thinking about, could you create a family history tool that thought about access to clinics and access to healthy foods and housing and pollution and stress and access to exercise as sitting around what you might consider a more traditional family history in the middle. And this was just, again, his let me try to do this in a couple of days and see what it looks like. But this would be the idea, which is to kind of give a fuller picture of a family history tool than what's normally done, right? Where you still have that kind of traditional family history in the middle, but you have kind of the social and behavioral things kind of on the outside, kind of showing that multifaceted, multiple determinants of health. And, the idea might be to create a better understanding of risk by including social and environmental exposures, that this data might help to, trigger physicians and patients to address plans together, like we were talking about with health navigators, and might also help individuals and communities learn about their exposures, right? If you kind of think about family history tool as something you could take back to your family, every year Thanksgiving is National Family History Day. You can imagine wanting to have these kinds of conversations. And I also think, and this is where it gets a little bit future thinking, is that we also want to think about this as translational in terms of genomics, right? So as I said at the beginning, we do think that understanding complex genetic risk assessments are limited by a lack of understanding what the social environmental features that the patients who are getting genome scans potentially in the future might be. So take, for example, if you find that you have a genetic predisposition to lead exposure or to heavy metals, right? Knowing the physical conditions in which people are living in, along with that genomic information, we believe would be more helpful in thinking about addressing prevention plans, in thinking about messaging, in thinking about the ways in which a family might talk about, I just got my whole genome sequenced. Now what, which again is a very, definitely in the future, but doing so without better understanding the social and environmental profile in which people live in, I think is really limiting genomics, right? This is our other world. This is our genetics world, and so making assumptions about individuals and communities may lead to excluding some communities from the benefits of genetics. So one of the things that we found in our other work related to this is that if you look at the genetics clinics that are out there now, the ones that are kind of I wouldn't say leading the charge, but are kind of a little bit more edgy and trying to say, look, everyone should get a whole genome. You should just have it on a disk. It should be part of your medical record. If you look at the rhetoric on a lot of these personalized genomic sites, very few, if any of them, talk about the need to think about the implications of genomics in underserved communities. And some of the rhetoric includes, well, they've got bigger issues to deal with. They don't need genetics. They're worried about getting to the clinic in the first place. And one of the things that we've heard from our focus groups, from our interviews, that's just not true. People want access. They want access to good technology. They don't want to be left behind. They don't want to, know that, oh, well, you have to, have a lot of money in order to get the benefits of genetic risk profiling. And so that's kind of been a theme of kind of thinking through where this is going. Yeah, please.
Yeah, but I can't help thinking that everybody who does access all the data that is available on that little disk does have all of the financial and emotional and every kind of other resource that you can think of to do something with this.
That's right.
Plus, they also have the time or the resources to hire somebody who has the time to do it. Now, the picture that I have just painted is the picture that is marketed to everyone. Yeah. Not just the Rothschilds and Cox and whatever. And so what you are doing, what I hear here, is a tremendous generation of one thing that can never be met, which is expectations. So I'm sitting here just thinking, yeah, this all sounds real great, but I don't hear mention of time to address these. I don't hear mention of expectations that will be increased. One of the things I've written down here is there's a tremendous increase in expectation without a tremendous increase in providers. And
That's
everybody
right.
in this room knows exactly where funding, especially low-income funding, is going.
That's
I
right.
had somebody explain the woodwork effect to me, but she got halfway through the explanation and I really, really got what she meant.
Yeah. So I think you're raising huge issues. I think you're raising really important issues, and we're at the end. This is a perfect time to start the conversation. I would say that I would agree, but there are two further problematize it, which is that genomics is getting incredibly cheap, right? To do a whole genome, even 3 years ago, was $10,000. Now it's $900. And every day it's getting cheaper and cheaper to the point where it's going to end up being, $100 to get your genome sequenced. And that is not so far in the future. The problem is, which you're raising, is that you can do that for $100, but there are only 2,000 genetic counselors in this country. There's only, I think, 1,200 medical geneticists in this country. There are states, I just was looking at the numbers yesterday. There's a state, I think it's Alabama or Mississippi. It's in the South that only has one genetic counselor for the entire state. One genetic counselor. So if you need genetic services, there's no one else to do it. Now, that being said, I also think that's what's going to start happening is that as genetics starts getting integrated into clinical services more readily, clinicians are going to say, well, we don't need genetic counselors. We don't need medical geneticists. We can just order this ourselves. And that's actually, just to even more problematize what you're saying, is that then what? You have people who've never been trained in genetics trying to interpret incredibly complex results. So I do think you're right. In terms of expectations, we have to be very careful. What I worry about is that when people make those claims, which I agree with, that it's complex, that it's hard, they tend to add, not everyone, I'm generalizing, so please forgive me, they'll add things like, well, then we just won't have this in underserved communities. That's not what it's for. That's not what this is for. And I worry about the rhetoric of thinking about genetic technology as something that's only accessible to those who can afford it. And that's not a problem just in genetics. That's a problem in all sorts of medical treatments. So I agree that there's the problem of meeting expectations. I worry that having that be the end of the conversation gets us to a point where when we think about what we call genetics equity in genetics, that we'll never be able to get there if we just assume, I'm not saying you're saying that, I'm just saying that if we assume that it's just going to be, we're never going to be able to meet the expectations of underserved communities, so let's just not have this being off. Let's not have this on the menu of things that let's say could be ordered at neighborhood family practice. So I worry about both sides.
I want to make a quick comment. Sue, hold on to your thought just for just a quick comment. Your observations are so important and so true, and we do have these concerns. We worry about this kind of disconnect. Who actually is able to access this technology? And that said, it's really important for all of us to understand that genetics in clinical medicine is charging forward.
It's a train going.
That train has left the station, and from a scientific and technological perspective, advances are being made very, very quickly, and our organization of healthcare delivery, our capacity to deal with health disparities, our ability to deal effectively with chronic disease, disease prevention. We are so far behind. So this is happening. If you could imagine, it's like an overlay. It's like a genetics overlay. I mean, if you think about what's happening with genomic research right now, there's an overlay of genetics to everything else in medicine, everything else in clinical care and public health. And it's way out there, and we're like this.
I also think I think we've talked to lots of people about this project, and we have had lots of people who have said, they haven't framed it this way, but I'm going to frame it this way. What are the ethical implications of doing a project like this when we know we will never be able to meet those expectations, right? What are the ethics of creating a tool that assesses all these things when you know that meeting the expectations of trying to come up with a more holistic view of genetics and environment isn't in our grasp? And so we struggle with this because we think this is a really important idea, and we also worry about the potential implications for the clinicians, for the patients, of giving this kind of extra information or combining information in this way that might be incredibly problematic.
Responsibility.
That's right. That's right.
Yeah, so this is really, really interesting, and what I wonder is, given all the information that's available around genetics, there aren't that many things that are truly actionable, right? So, the vast amount of information we have, the information around what you can actually do and change that would have a real impact is actually, as far as I know, quite small.
Yeah.
Beyond, if we just said, okay, top 3 things: have a healthy weight, don't smoke, and move. Right. So the work that we're doing focus on those main health behaviors. Beyond. So this is what I really struggle with.
Yeah, no, I do too, and I think it's definitely a moving target, right? So I think for the most part, I definitely agree. There are some examples that are starting to come out as we learn more about actionable genetic variants. So that's a very loaded term, but actionable genetic variants. We're learning some examples of where gene-environment interactions are actually going to be incredibly important. So alpha-1 antitrypsin syndrome, right, is for many years has been thought of as kind of a gene-environment interaction where smoking clearly exacerbates, if you have the gene and you're also smoking. So having both gene-environment interaction in that way, when you get that genetic variant, is incredibly important. And now we're finding that exposure to chlorine is also affecting people with alpha-1. And so getting that information, there's a couple different interesting examples of where having gene-environment interaction information would actually be really helpful in kind of actualizing the usefulness of the genetic variant. But there aren't that many of those.
Right.
And I think there may be more in the future. And I guess our fear is that as we get there, if we don't do this side too, this is the part of me. This is the environmental part of me. That if we place too much emphasis on making sure we know what the variants mean in terms of disease causality, we're going to skip all the other environmental stuff, and that genetic clinics are going to be way behind.
Right. I think to follow up on that point, so there's not that many of them, which is true, but there are some, and the proportion of people to whom that affects, right? So the frequency with that gene variant actually occurs, it's small.
Very small.
But yet there's an awful lot of attention. There's lots and lots of attention. So I think this is really important work.
Yeah, no, it's a really important point. It's a great
But I
point.
would almost, it's interesting, I wouldn't have thought this initially, but when you said being behind, in some ways I just want to comment your last comment, which is that in many ways you may be putting yourselves ahead. Because in some ways, having the community have a better understanding that it's not just having them understand, all of us understand the connections of gene environment or susceptibility in environment, or however we want to describe it, is a new thing.
Yeah.
And it's just like the grasping of that could lead us to a lot of places we haven't even gotten there yet. So as things start to evolve, if people are already ready and thinking about it, new things will come from that we're not even able to conceive yet. And I would go back to your comment. I agree with from a clinical provider standpoint, the expectations may be difficult. But by opening this up to the environmental piece, now you're bringing in public health, planning, all kinds of things that other people do have input on how these environments, if anything, and that isn't necessarily the healthcare system.
That's right.
So it's not all going to sit on the healthcare provider's shoulders. It really should be, but if you don't have this happen, that recognition might not be there. So you may be more ahead of yourselves, or ahead of the than you think.
I appreciate it. Yeah, no, thank you. I mean, I think one of the things that we've talked a little bit about is, so right now, most hospital systems, in fact, except for I think one hospital system, no one's really offering what you might consider healthy genomics sequencing, right? You can't really go, unless you're paying for it yourself, it's not really a clinical service. There's a couple hospital systems that are playing with the idea. First of all, there's no such thing as a healthy genome, so that's just a whole, once you do genome sequencing, you're going to find something on everybody. So you go in with a healthy genome, you come out with something. So I think you're right, like now is the time, because right now it's typically used for, kids with kind of unknown syndromes, where you get a lot of things going on. And even in that case, genomic sequencing only really helps about 25% of the time. So we're really, while we're thinking about this big, we're really at the early stages. On your comment, Patty and I were at a talk at the recent bioethics meetings, and someone was talking about how genetics will eventually impact population health. And they were assuming that, so I don't know if some of you may be familiar with the kind of translational pipeline, the T1 through T4, right? And it's all clinical based, right? It's all about getting from what they call base pairs to bedside. So instead of bench to bedside, it's base pairs to bedside. And it's all about using the clinical infrastructure that will eventually then help populations. And we made some comments about that. Maybe it can come the other way. Maybe there's ways that genetics or genetic information within communities could be used to improve community health without having to just be only through a clinical genomic sequence that you're going to get from your doc, and it's going to be on a gold-plated USB drive like some of the companies are offering now.
Or more so, though, if the gene environment worked, we all know, someone doesn't know me, my opinion about this, is that I'm more hopeful at the environmental side of it. Meaning that if it comes down to saying that it's that environment, you're susceptible. Now, hopefully we won't go to blaming the individual now and say, well, see, like you just said, so move.
That's right.
If that's where we're going, then this really is going to go. But I would hope that this might eventually lead to us saying, okay, we got to do something about where people live. We can't continue to have lead in homes. Let's do something. And let's put the money, take a bit of this money that sits somewhere else, and put it to where we might end up having population health outcome differences.
And that's where I think Laura, in the interviews with the providers, really saw is this: when we get this information, are we just condemning both providers and patients to, well, now you know you're genetically susceptible and you're environmentally susceptible, so good luck with that, that's why, I mean, we've been trying to be as self-reflective as possible at this project. We're skeptical too about where this might go and what the implications might be, and I think there is that kind of, and maybe your suggestion of kind of taking it out of that doesn't have to just be about the clinical encounter, which we've talked about before. There might be ways to think about how this kind of dual information might be helpful in other settings, like policy making, like thinking about community planning, community neighborhood boards. So really helpful. Other questions or comments? We'd love to.
I don't want to hog the floor, but along with what you're talking about, environmental stuff, is there any way to make remediation cheaper? All kinds of environmental remediation.
There's a lot more better experts than me in this room about that. I'll let other people.
It's just money. It's really where the money goes. Public health is 1/10. That's the problem, is that the way in which our GDP is distributed, it goes more to healthcare than it goes to prevention. Right? And so as long as that continues to be the case,
but to me, remediation is in the prevention universe, at least in this, where we're talking here. And when I hear about how much it costs to remediate a plot of land, in all these homes that have been taken down, I'm shocked.
How expensive it is.
Yeah. And it's amazing. This is we're talking about this at an interesting time where the budget is about to come out that's going to have money for the precision medicine initiative, and it's amazing how much of that is focused on individualized clinical treatment. That's going to be the answer. And this is coming from someone who actually, I do some work in the PMI, and I'm fairly supportive of it, but I'm very skeptical about we're going to create a 1 million person cohort. And collect gene-environment interaction, apparently, and it's going to help us to prescribe better. It's going to help us to, do X, Y, Z better. And there's not a lot of public health talking about it. There's a lot of talk about how public health can add into the PMI, not a lot about how public health will benefit from the PMI. And maybe it's because they don't know yet, but I do worry about the potential for personalized medicine to create a rhetoric, an ongoing rhetoric that leaves public health in a very, very, very predicament. I looked at APHA, just out of curiosity. I looked at APHA, I didn't go this year, but I looked at you can go online and search. and there wasn't one talk about precision medicine in the entire, 600 abstracts. Yet if you went to the bioethics meeting, there were like 70 in a much smaller talk. So I mean, I wonder if we're talking in two different realms at two different levels, and we need to maybe bring them together
There's
more.
an opportunity for editorial, some sort of high-level editorial that would be able to catch the eye of folks that come at this different.
That's right. And I don't know if anyone was at last year's APHA, but the idea was about how space and place affect health. And there was a keynote session called When Zip Code Trumps Genetic Code. And I went to it, and it was an interesting session, but I felt like genetics was set up as a straw man to say, look how important look how important social and environmental factors are in health. It's so much more important than genetics. And while I maybe don't disagree with that in a lot of ways, there wasn't a lot of how do we put these things together, right? Rather than one trumping the other, how do we actually think about these things together?
But in fairness, though, you made a comment earlier about what if we find out that you're more genetically, if you live in a house with lead, that you're more genetically inclined to have X. But we could say, I don't need that. I can tell you already.
That's right.
That you have kids living in these lead houses that we're doing nothing for.
That's
so
right.
I think that's kind of the reason why it gets into that discussion, because public health folks are like, we could have told you all this, we don't need.
And to be honest, that skepticism's happening just in the genetics world, where the genetics people are saying, okay, you're going to give me this, this genome scan. I gave you my family history 2 weeks ago before you took my blood. I could have told you I was at risk for heart disease, diabetes, cancer. And so why did I just spend $2,000 on a whole genome sequence that now I've got in my medical record?
I want to insert a different. I want to look through another lens here. And I don't know if I'm going to be real articulate saying this. So, if you think about cancer as a public health issue, in the sense that sooner or later, how many of us in this room will have cancer? I already have had cancer or heart disease. I mean, that's a public health chronic disease issue. And cancer is often these days treated more like a chronic disease because treatments are helping. So in this area, the area of cancer, genomics, genetics are being effective for all individuals who are being tested to identify care pathways. So their tumors are being analyzed genetically to make a better determination of what approach, what chemo drug, what,
That's where precision medicine makes sense.
Yes, and I think of it, I don't know how to articulate it as a public health issue, but I think of cancer, I think of heart disease as public health issues because they cross a demographic, ethnic, people everywhere wind up with these issues.
Any other comments or thoughts? Or this is helpful to start thinking through this, so we really appreciate it.
The only other question I have you guys been running into more, I just went to the inaugural population health, I'm wondering if some of this is also there's going to be a new realm. Because in the population health field now, it's a field or an approach, you have both the clinical and the public health components coming together, but with the idea of it being population health and not necessarily public health being more the application or the, you know what I mean? So when you go to the genetics meetings, like are even the
So genetic epidemiology is a perfect example of where you would find individuals who are doing, collecting samples, gene and environment and social data on huge numbers of people.
Yeah, I think it's starting. Yeah, I think in genetic epidemiologists in terms of gene variant, that kind of stuff.
Yeah.
I think Where you don't see it as much yet is when that gets translated. It still gets translated. The pathways that are laid out are still very clinical pathways when it gets translated, and so I think you're starting to see some use of kind of the language of population health and thinking about that. There's also, not that it's any secret to anyone in this room, there's a lot of trepidation and a lot of hesitation about using genetics in population language based off of the eugenics movements, based off concern about the assumptions we make about populations and stigmatization and discrimination. And so people are more comfortable talking about genetics on an individual basis within the clinic. They get a little bit more uncomfortable, for probably incredibly real reasons, about thinking about genetics on a population level. Even though we know the goal is to improve population health, there's a lot of concern, I think, about using some of the kind of genetic prevention language, so that what we might call genotypic prevention versus phenotypic prevention in a population setting. It raises a lot of bad memories, and so I think most people have stayed within the kind of context of the clinic. Although that's changing, and I think that's
I was just thinking maybe it isn't going to come out of the normal places we're thinking. Maybe it's going to emerge from a new space. Is what I was thinking. Is there, and what would that new space be?
I also think this is, you could just give the whole course on this. There's a big movement for direct-to-consumer genetics, where you're able to, you take a swipe of your mouth and you send in $100 or $200 or whatever coupon you got from the New York Times. They really do have coupons. And then you get your personal genome back. And, the FDA has gotten involved. So there's a company called 23andMe. Some of you may have heard of it. They're right now not really doing health-related data. They have Bloom syndrome, carrier testing for Bloom syndrome. But I was just at a meeting a couple of days ago with the director of innovation for 23andMe, and they're talking about getting more health data back online. And the idea is this is outside the clinic. It's community-based. It's personal. It's you and your family can all get swabbed. Do a swab party. They and you all get swabbed. And you send in and you get your genetic information back, and you look at it together. And it's meant to be outside of the clinic. It's meant to be about community and family. And before today, I always thought really negatively about it, but maybe there's something to this idea of kind of putting genomics into the community in a different way, So I don't know. I hadn't really, and there's going to be more companies like that. There's probably 3 or 4, and you're going to start seeing more and more. And the FDA is getting involved, but you're going to start seeing more swab parties, I think. You can go on, you can gift someone, for the holidays, you can send them a gene kit,
That's what I always wanted.
Yeah, that's right.
You can even do it for your pets.
Yeah, you can do it for your pets. You can they allow you, and they allow you to do it for your children. So someone at this meeting said, "How can you get your kids to swab to spit into a cup?" And someone said, "My kids are always spitting." That's probably the easiest thing to do.
So please join me in thanking our.
Thank you guys very much.
And just a reminder of upcoming presentations. Next month will be a presentation on the survey work from the freshman study. Thank you. If you're interested in presenting.